Charlie's a healthcare policy analyst at the Wyoming Liberty Group. Prior to joining the Liberty Group, Charlie interned at the American Action Forum, Freedom Works, and the Reason Foundation on issues ranging from regulatory policy to pension reform. He received his undergraduate degree in economics from the University of British Columbia. So if you would join me in welcoming Charlie. Petit. Okay, it's on now.
Oh, it is? Okay.
Yeah.
All right. So should I talk? All right.
It doesn't matter.
Oh, it doesn't
If
matter?
you like to walk around, this one's better.
I might like.
Are you going to do that
might
one?
try and stay around.
Okay,
Yeah.
that's good.
All right. So, as Kathy. Oh, sorry. All right. So as Kathy said, I started working at the Wyoming Liberty Group pretty early. So in February, I started working, and as you know, that was when the entire Medicaid expansion issue came up again, and I was thrown into the research and the debate. And I was just bombarded with all these arguments that were being made for Medicaid expansion. And the reason why I'm here is I want to make sure that you guys know how false those arguments are. Because those arguments are going to be made again next time in 2016, this upcoming year. And the reason why is because 2016 is going to be the last year in which Wyoming does not have to pay for this expansion in the Medicaid entitlement. Afterwards, it's going to go down, but the reason why is because that is their selling point. They're going to say that this is free money, and Wyoming doesn't have to pay for it, and as a result, the most vulnerable in society get better care. So, as you know, it was defeated, but they're going to try one more time. But the reason why I'm here is to educate you on not just how terrible this entitlement is for taxpayers, but also, perhaps even most importantly, it's actually terrible for patients. So they always couch Medicaid expansions these arguments for Medicaid expansion in that it's worth paying the price for, in that even though it's going to cost some money, you're giving people health care. But I'm going to show you that it's most horrible for patients. And I'm going to go in and tell you about basically the history of Medicaid, what its structure is, and why it's always been this way. And how even though there are going to be arguments about how there are going to be adjustments in co-pays, in how much Wyoming has to cover, it will always be bad for patients and will always lead to higher costs for taxpayers. So what I'm going to talk about first is... Okay. So I'm going to talk about Medicaid's history, how it got to this point, what Medicaid is right now, and what Medicaid expansion is going to be promising, and why it will fail. All right, so in the beginning, Medicaid expansion was a pretty humble program, actually. It was going to be used as just a way to finance existing charitable programs and welfare programs. There would be a baseline if you're a state and you wanted to access these benefits. You had to cover a few basic medical services, inpatient and outpatient. And the beneficiaries in which you were going to cover were fairly minuscule as a portion of the population. There were low-income children, their parents, and the disabled. And the way how this was paid for is states would pay a portion of the cost, but the federal government would also cover a great deal of the program. And this cost-sharing arrangement, as I'll explain in the next couple slides, is why this program continues to expand at the cost of taxpayers and ultimately at the cost of patients as well. So the way how these incentives are so perverse is that for every amount that a state puts in, a dollar that the state puts up for Medicaid, the federal government will chip in $1.33. Now this varies from state to state. They use a formula where lower income states get a higher percentage. So for Wyoming, for every dollar we put in, the federal government puts in $1. But for other states, for every dollar that, say, Mississippi puts in, what the federal government will contribute $2.81. So basically, politicians can promise these huge benefits, and they can promise to expand eligibility because ultimately when they make these promises, they can say that the state is only paying for a fraction of the cost of care. And this is exactly what's being done right now with Medicaid expansion. Medicaid expansion is simply the latest example of this trend, where they promise expanded eligibility, expanded benefits, and they say the feds will pick up most of the cost. So, and that's what happened. They expanded eligibility at the federal level, so elderly and the disabled came on in '72, and pregnant women came on in 1984. And this is the current arrangement right now at the federal level. So you have to meet these percentages. These are the amount of people states have to cover. You can't go any lower if you accept Medicaid money. But you could go above that, which is what states have been steadily doing. And benefits as well have been increasing. Like I said before, it was pretty basic, the kind of benefits that were being offered, inpatient, outpatient. Then they started expanding benefits, prosthetics, chiropractic services. One of the most expensive ones actually is long-term care. So long-term care is it's technically not healthcare, it's basically nursing and home care for people that just are physically incapable of feeding themselves, going to the bathroom, dressing themselves. But this is a really expensive form of health care. And Medicaid is currently paying for 62% of the cost of care. And that is and that is going up. So the result of all this, where you incentivize states to pick up, to promise to cover the healthcare costs of more people, and you encourage them to promise more benefits, the result is, as we saw, greater enrollment. It's gone up by 250% just since 1974, and the cost has gone up. But the question you may ask is, how are states able to pay for this? And the thing is that the way they've been able to pay for this actually is by bringing down the cost of reimbursement, because states are able to adjust their reimbursements on a year-to-year basis, and they're able to keep promising and saying, we are going to cover the elderly and the poor, and we will cover their benefits. But this is all dependent on whether doctors are actually willing to take these patients and willing to see them. So as we see, this is Medicaid's reimbursement by state as a percentage of what Medicaid pays doctors relative to private insurers. Now, the states that have some of the lowest reimbursements, coincidentally, actually have some of the highest eligibility levels. So these 10 states, New York, Rhode Island, New Jersey, California, very liberal states. They've expanded benefits a lot. And they've also expanded eligibility as well. So the average eligibility, so there are 5 eligibility categories. The average percentage of the federal poverty line is 162%. That's even more than what Medicaid expansion is promising. This is what these states are promising. And their average reimbursement as a percentage of what private insurers pay is less than 45%. So if you're a doctor, why would you choose to see Medicaid patients when you have a long line of people with private insurance? And that's what's happening, actually. There was a professor, I believe, at the National Center for Health Statistics. She actually looked at what was Medicaid paying as a percentage of Medicare. Now, Medicare pays less than private insurance, but they pay 80%. So they still pay more than what Medicaid is paying. And for now, at least, doctors are pretty willing to serve Medicare patients. So she looked at how much was Medicaid paying in certain states, and how many physicians were actually willing to serve Medicaid patients. And there was actually a strong correlation between the fact that the lower you decide to reimburse doctors, the less that doctors are actually willing to serve those patients. So this is actually, it's not just terrible for taxpayers, it's horrible for patients. And on average, 31% out of all the states, the average state, there are 31% of doctors that now refuse to even take new Medicaid patients because they are losing money, essentially, with every patient. Now, if you're somebody on Medicaid and your access to care is being curtailed so much, then you are going to starting to have some health problems. If it's so long, if you're having longer wait times and finding it hard to see a doctor, then you're going to start putting off preventive checkups and regular visits, and conditions are starting to fester. There was actually an excellent study that was done by 2 Harvard economists in Oregon. And before Obamacare, they did a bit of a Medicaid expansion of their own, but it was a lottery. And what these 2 economists did is they looked at the health history of patients that won the lottery and got onto Medicaid, and they looked at the ones that lost the lottery and did not get Medicaid. And they looked at what sort of doctor's visits they did. And they found that Medicaid patients actually use the emergency room 40% more than patients that were not. They found it so hard to go and actually see a doctor that these problems continued to worsen, and they were forced to go to the emergency room to actually access care. This is the most famous study that's been done, but there's been other ones over the years. There was another one by the University of Pennsylvania, and this is pretty comprehensive. They looked at 900,000 surgery procedures that were done across the country, and they found that people they were comparing Medicaid patients with people that use Medicare, private insurance, and the uninsured. And Medicaid did worse than all of them. But what's interesting is that they did worse than even people without insurance. They were just paying out of pocket, and they had 20% higher costs because they ultimately went into surgery when a doctor finally was able to see them after a lot of times of not being able to see a doctor. Their hospital stays were 50% longer for exactly those reasons, and they were 13% more likely to die in the process, just because their health problems had deteriorated so much. University of Pennsylvania also had a really good one where mortality for surgery for colon cancer was 27% greater for patients on Medicaid. By the way, if you guys have any questions, feel free to ask me in the course of this. That's the history that I gave, the course that what Medicaid has been going through, and what the current state of Medicaid's relationship is with doctors and patients. Now I'm going to talk about basically what Medicaid expansion is supposed to be doing. Now basically what Medicaid expansion is going to be doing is, remember this is the federal eligibility prior to Obamacare. If you're a state and you choose Medicaid expansion, all these arrangements are scrapped. You just fit the 103% of the federal poverty line, meaning anyone in that criteria, whether you're a pregnant woman, school-aged children, an adult with disabilities, or even a childless adult, your state has to cover them. And like I said before, they're going to pay, the federal government said they're willing to cover 100% of the cost of this expansion until the end of 2016. And afterwards, the reimbursement rate for states will go down to 90%, over the next few years and stay that way. That's the promise. So this is what's currently the state. 30 states have expanded and 20 have refused for exactly the reasons which I said, in which the dynamics of Medicaid expansion are the same ones that have been done throughout the history of Medicaid, where if you're a politician, you can say, we're going to expand health access for millions of people, give them access to a whole bunch of benefits, and it's only going to cost a fraction. It's only going to cost a fraction to us of what it's actually going to cost. So this is why Medicaid expansion has been so successful. One problem, though, is that they really underestimated enrollment. So back here, about 90, they were willing to cover 90% of the cost. I mean, the federal government was willing to cover 90% of the cost, and states would cover 10%. What they didn't take into account is they didn't take into account the fact that those costs, there are going to be higher relative costs in terms of, is the federal government actually going to keep that promise? That was something that was brought up, but nobody actually looked into what is the track record of the federal government actually keeping their funding promises. And the other one is the absolute costs. Are states going to is that 10% cost for Medicaid are they actually going to have to be paying far more? And what we've seen actually is that out of those 30 states, 16 states have posted what their actual enrollment numbers. And we can actually look at what they were compared to what they predicted. And 16 states, their actual enrollment was 96% higher than what they actually predicted in 2014. And it was 21% more than what was projected, what will be projected in 2022. So basically, we've gone over the last over 1 year, the Medicaid's enrollees has increased more than what the program expected it to do over the next 8 to 9 years. So these states are going to be stuck with double the cost that they were expecting. Colorado, our neighbor to the north, was the worst. They underestimated their costs by 207%. So they're going to be paying 3 times as much for Medicaid expansion. Also, there is a long history of the federal government breaking their promise to states in terms of what they were willing to cover for federal programs. In 1975, there was the Individuals with Education Disabilities Act. And what the federal government promises, if you're a state and you want to expand an education program for children with disabilities, the federal government would cover 40% of the cost. And if you decide to go along with this program. Well, a bunch of states did. And in every year after 1981, they never kept that promise. So states have been paying $250 billion more over the last 40 years than what they actually promised. And a big reason for this is people talk about how it's basically free money. Well, the federal government may operating on an entirely larger monetary scale than what states are, but there are still constraints on how much you can spend, how much you can borrow, how much you can tax. And so during the fiscal cliff debate, when they had to make cuts of $50 to $100 billion as part of the debt ceiling deal, they made cuts to discretionary programs that a lot of states relied on. The minerals royalties that Wyoming relies on, they took a severe cut when they decided to withhold $111 million to a bunch of states that were producing this mineral wealth. Highway funding was also cut, so was CDC money. And the reason why is because the federal government is not like a person or a company in which you engage in contracts with, because that contract was written by them. Congress writes the laws, and if they get into budgetary constraints, they are perfectly free to amend the laws, change the laws of these supposed contracts, and go back on their deals if it's in their monetary interest. And this isn't just looking at history and saying, what is the federal government going to do based on its prior history? The federal government has already been proposing cuts to Medicaid expansion, or to the Medicaid program. So in 2013, while the Obama administration was going around states and telling them about how great this deal is, and that you can cover millions of more people, and it would essentially be free, one of the proposals the Obama administration put to Republicans in Congress in terms of a budget deal was to drastically cut how much Medicaid was going to reimburse states for as a percentage of the program's costs. So right now, as I was saying before, there was a funding match for Medicaid expansion. they're willing to cover, in theory, 90% of the cost, and states would be responsible for 10%. But there was a different formula for the traditional Medicaid system. So like I said before, for every dollar Wyoming puts in to the program, the feds will put in another dollar. But what they were proposing was scrapping all those different rates and just having one blended rate, which would be an average of the traditional rate for Medicaid and the expansion rate. And the Heritage Foundation actually took a look at what this would do to the burden that states would have to take hold of and pay for if these changes went through. And it would, over the next 10 years, the cost to states would go up by $78 billion. And if Wyoming went along with Medicaid expansion, we would have to pay an additional $76 million over the next 10 years. So what do we know now? Medicaid, the way it works is that with every dollar states put in, the federal government is willing to put in so much more. So politicians have a huge incentive to promise tons of benefits, but it's okay because the feds will just cover most of the cost. And if the costs continue to go up, they won't actually, it's very deceitful what they do, because rather than admit that we overpromised, what they'll do is cut costs in a very deceitful way by cutting the reimbursement rate for doctors. But so it looks like you're not actually cutting any promises, but you're actually cutting the access that patients have to this this healthcare program that they've been relying on. So with every new expansion, the costs rise and access declines. And Medicaid expansion is just not new. It's the latest in this trend where access continues to deteriorate and the costs continue to rise. So